All right, let's get into it. Today, we're cracking open the schematics for the most complex, most powerful, and sometimes most terrifying engine there is, the human mind. Our mission is to understand depressive disorders, but we're coming at this like master engineers. We're here to diagnose the system failures, to understand the grim mechanics behind them, and to master every single tool required for a full repair.
So this is our master blueprint for today's deep dive. We'll start with what happens when the engine goes cold. Then we'll run through a whole catalog of malfunctions, learn how to read the schematics for diagnosis, and open up the mechanics toolkit. After that, we descend into the pharmacological forge, and finally, we'll put it all together in the complete blueprint for repair. Let's fire it up.
First things first, we need to reframe this whole thing. Depression isn't just the blues or feeling sad. No. From an engineering standpoint, it is a critical system failure. It's what happens when the main engine, the one that powers your mood, your motivation, your very will to live, starts to sputter, stall out, and just go cold. And when that core engine fails, it takes every connected system down with it.
Now, the primary system failure we're dealing with is major depressive disorder, or MDD, and the official specs on this are super precise. This is not a bad week, you guys. This is a significant change from how a person normally functions. You need at least 5 specific clinical findings, things like a depressed mood or a total loss of pleasure. And here's the kicker. It has to last for a minimum of 2 solid weeks.
You know, this machine, it can break down in a whole lot of different ways. Depressive disorders aren't just one thing. They show up as a whole catalog of different malfunctions, and each one has its own unique specifications. A good mechanic, a good nurse, has to know exactly which breakdown they're looking at to even think about choosing the right tools for the job. So let's compare 2 of the most common failures side by side. Think of MDD as an acute, severe breakdown, like the whole engine just seizes up, bam, all at once. But persistent depressive disorder, PDD, that's different. That's more like a chronic grinding gear. It's milder day to day, but it's relentless, lasting at least 2 years in adults, and it just slowly, painfully erodes the entire system over time.
And beyond those 2, you've got these specialized malfunctions. Seasonal affective disorder, or SAD, is a failure that's literally tied to how much light is available. PMDD is a cyclical failure, synchronized perfectly with a menstrual cycle. And then there's postpartum onset, and I need you to listen very carefully here. The warning on this is critical. This failure can happen within 4 weeks of giving birth. It can involve delusions, and it creates an incredibly high-risk situation for the baby.
Okay, so you've identified a potential system failure. The warning lights are flashing. What do? This is where you, the nurse, become the master mechanic. Your job is to meticulously inspect the machine, to read the schematics of how that patient is presenting, and to pinpoint the exact nature and severity of the breakdown.
This is your diagnostic checklist. Memorize it. And the order is completely non-negotiable. You assess suicide risk first, always. Before you do anything else, you have to determine if the primary boiler is at risk of a catastrophic rupture. Only after that's clear do you move on to observe their affect, check for that lack of energy and loss of pleasure, and then assess the physical systems and their ability to function day to day.
And this right here, this is why listening is your most important diagnostic tool. A cry for help isn't always a direct scream. Sometimes it's a quiet, covert comment, just like this one. When your patient says, "Everything is looking pretty grim for me," every single alarm bell in your head needs to go off. That is a massive red flag for potential suicidal thoughts, and it demands an immediate, direct follow-up.
Okay, diagnosis is confirmed. It's time to open the toolkit. But before we start mixing up the potent chemical cocktails from the pharmacy, we have a whole range of powerful physical, environmental, and therapeutic tools that we can use to start the repair process.
Our toolkit has a lot of layers. We can start with milieu therapy, which is basically creating a completely controlled therapeutic environment. Think of it like putting the whole machine in a specialized repair bay where every single interaction is structured for healing. Then you've got psychotherapies like CBT. This is like debugging the machine's core programming, helping the patient find and literally rewrite the faulty code in their own thought patterns. Group therapy is all about reducing that systemic isolation, reconnecting circuits that the disorder has severed. For SAD, light therapy is our specialized tool, kind of like a focused energy beam. And for the most severe, stubborn, treatment-resistant malfunctions, well, for that, we have the full system reboot, electroconvulsive therapy.
Let's take a closer look at the schematic for ECT.
Now, this is not a first-line fix, okay? This is for severe cases that haven't responded to anything else. The procedure itself involves a series of controlled seizures, and the nurse's role is absolutely critical. You're giving pre-meds like atropine and succinylcholine. And see that warning? ECT is absolutely 100% contraindicated in patients with major cardiovascular or cerebral vascular problems. After the procedure, your job is simple: vigilant, constant monitoring.
And now, we descend into the pharmacological forge. This is where we craft the most intricate, the most powerful, and frankly, the most dangerous tools in our arsenal. These are the chemical agents designed to rebalance the very neurochemistry of the mind's engine. This is high-stakes, precision work, people.
Before we even talk about a single drug, I need you to burn this number into your brain. 4 to 6 weeks. That's how long it can take for an antidepressant to really kick in and reach its full effect. Why does this matter so much? Because a patient's energy might start to come back before their mood actually improves, and that creates this incredibly dangerous window of highest risk for suicide. This is one of the most critical safety points you will ever teach a patient. So our first-line tools are the SSRIs, like fluoxetine. You can think of them as pressure regulators for serotonin. They block its reuptake, which means more serotonin is left floating around in the synapse. They work well, but they have common side effects. And, this is huge, they carry a black box warning. That's the FDA's most serious warning for an increased risk of suicidal thoughts, especially in younger patients. Next up, the TCAs, the old guard. These are powerful. They're like dual-fuel pump inhibitors, blocking the reuptake of both norepinephrine and serotonin. But that power comes with serious risks. They cause major anticholinergic effects. Think of it as drying out all the system's fluids, causing dry mouth, blurred vision, you get the picture. They also cause orthostatic hypotension, which is a sudden pressure drop when a patient stands up. And here is the lethal warning. TCAs are incredibly toxic to the heart in an overdose. A 1-week supply can be fatal. We never dispense large amounts to a patient who might be at risk. And now for the heavy artillery, the MAOIs. These things are enzyme deactivators. They work by knocking out the enzyme that breaks down neurotransmitters, which causes a massive flood of norepinephrine, dopamine, and serotonin. The price for all that power? A catastrophic warning. If a patient on an MAOI eats tyramine-rich foods, we're talking aged cheese, red wine, salami, it will trigger a life-threatening hypertensive crisis. The dietary education here isn't a suggestion, it is a matter of life and death. And finally, we have the specialized gears, the atypical agents. Bupropion is unique. It hits dopamine and norepinephrine, and it's also used to help people quit smoking. But here is the key fact you need for your exams. It lowers the seizure threshold. That means it is absolutely contraindicated in any patient with a seizure disorder or an eating disorder. Then you have trazodone, which is another specialist, often used for its heavy sedative effects to treat insomnia.
Okay, this is it. The apothecary's ledger, your master chart. Let's hammer home these nursing gotchas, because this is where the points are won and lost. For SSRIs, it's that early suicide risk and the risk of serotonin syndrome. For TCAs, they are lethal in overdose. For MAOIs, hypertensive crisis with tyramine is the big one. And for atypicals, remember, bupropion lowers the seizure threshold. You need to have this slide burned into your memory. So all these drugs work by cranking up the neurochemical pressures in the brain. But what happens when those pressures overload the whole system? What happens when you get too much of a good thing, or when these incredibly potent chemicals start interacting in dangerous ways?
Well, this is what happens. You get a catastrophic boiler explosion in the mind. On the left, you have serotonin syndrome, caused by way too much serotonin. The key signs are agitation, confusion, fever, and muscle rigidity. On the right, you have the hypertensive crisis from MAOIs. The hallmark symptom there is a sudden, severe headache and blood pressure that goes through the roof. Make no mistake, both of these are medical emergencies that require immediate action.
Okay, we've examined all the ways the machine can malfunction. We've learned how to read the schematics. We've studied every single tool in both our non-pharmacological and our pharmacological kits. Now, it's time to assemble the final blueprint. This is all about strategy, matching the right munition to the specific malfunction. And here it is, our strategic guide. For your most common depressive and anxiety disorders, you're starting with first-line munitions, like SSRIs. The heavy ordnance, your TCAs and MAOIs, you save those for the really tough, treatment-resistant cases. For SAD, remember,
Light therapy is a key first-line tool. And for something like psychotic depression, you're combining forces, bringing in an antipsychotic or even ECT. And those warnings, they're always there, reminding us of the risks we have to manage every single day.
We've been through the darkest parts of the factory floor tonight. We have looked at catastrophic failures, and we've handled some incredibly dangerous tools. But we end on this note, because the mind, for all its potential for failure, is an intricate and beautiful machine. And by understanding its schematics, by mastering the tools of repair, you are now equipped not just to pass a test, but to actually help mend it. And that is the essential work you're preparing to do.